Dear Facebook Pure Urology viewers, good evening one and all. As you all know, we are doing surgical technique based video presentations every alternate day like that. Today we have selected the topic Supine PCNL. The speaker is my close friend, the junior in Chandigarh, and who is a professor in medical college in Kolkata, Sunirmal Choudhary, and he is doing supine PCNL before I started, and he has gained experience. With this, he will present in different clinical scenarios what are the supine PCNL he has done, so that we can learn something from that. As you know, supine PCNL has because now for last 3 years, 2.5 years, I am doing supine PCNL. Certain definitive advantages they have, like in anesthesia point of view, compromised patients who cannot be put in prone position, obese patients. These we used to listen regularly in conferences, but once you start doing it, we realize that main thing is retrograde intrarenal surgery can be combined with supine PCNL, then it becomes ECIRS. Lot of arguments, lot of discussions happen, but it's not that supine PCNL is not at all necessary. Some situations it is necessary. Let us discuss with Dr. Sunirmal Choudhary where he has done, how he has done in different clinical scenarios. Before we go to the program, I will ask few details of Sunirmal. Good evening, Sunirmal Choudhary. How are you?
Good evening, sir. I'm fine.
Thank you very much for taking out time. I know you are in a government institute teaching as well as in the private practice. If I remember correctly, in Chandigarh, PGI, you did your urology training. Which year the training was?
It was 2010 to 2013, sir.
So I left at 2006. So 2010 to 2013.
Yes, sir.
After PGI Chandigarh, what was in your mind? You went direct. You are from Kolkata.
Yes, sir. From Kolkata, sir.
So you went back to Kolkata immediately?
Yes, sir. Yes.
So then you joined government job immediately?
Government jobs immediately, sir.
So that was in your mind to join. What were your areas of interest after the PGI Chandigarh?
Sir, initially my area of interest is uretroplasties because Dr. S.K. Singh loves me, so I am assisted in quite a lot of surgeries. So initially it was uretroplasty.
Yeah.
But later I felt that I have to in government setup you cannot choose your surgery.
Yeah.
You cannot choose a surgery. So I have to have some sort of skill in every surgery.
Yeah.
So that I can provide the benefit to the patient.
So you moved to endourology more.
Yeah.
So stone is compulsory. You have to do in private practice.
Yes, sir.
So stone is like a must surgery for urologist.
Yes,
apart from your specialty, you have to do that. So
yes,
you have done prone PCNL many years and then went to supine?
Sir, I started prone PCNL because I have learned prone PCNL at PGI Chandigarh.
Yes.
So at that time there was no concept of supine PCNL. So later, due to some special clinical scenarios, I was forced to start supine PCNL. It is not that I was very inclined to supine PCNL.
You have done some training, or you started yourself thinking and
so
then?
I started yourself. I started by reading a book. I have read a book on supine PCNL by Dr. Skofon et al. And read a few articles by Dr. Bhaldiga Erudia and other some articles. So I planned to do a supine PCNL because at that time, quite a lot of patients has got respiratory problems. So anesthesia was very keen that they are cancelling the cases for prone PCNL. So in that time, I have thought that why not supine PCNL? So that I will show one video of supine PCNL spinal anesthesia in COPD patients, sir.
Yeah.
Because in some cases that you have to do supine PCNL in that
Yes.
supine position in spinal anesthesia.
So in government institute also you are doing supine?
Yes, sir.
And you are training your students also. Do you have MCH
Yes,
program?
Sir. Yes, sir. We have got the 10 MCH students per year, sir. Now.
Oh my God.
Yes, sir.
So you are training them also supine PCNL?
Yes, sir. They are trained both in prone and supine.
Very good. So with this introduction, I will officially present about you, Sunirmal, and then I will hand over the program to you so that we can listen the important. So dear friends, please inform your friends to join Facebook Pure Urology, because now the activity among the friends increased in the surgical techniques, and we are sharing all the types of surgeries, so it will be useful for the urologist. So today topic is supine in different clinical scenarios. Dr. Sunirmal Choudhary is MBBS, DA, MS, MCH Urology. He is Associate Professor, Department of Urology, IPG, MER, and SSKM Hospital, Kolkata, West Bengal. He is the Alex Secretary, Bengal Urology Society. Oh, good. More than 30 national and international peer-reviewed journals. Awarded Bengal University, BUS, Bengal Urology Society Traveling Fellowship in 2018 Kolkata. Awarded second prize for video titled Supine PCNL Morbidly Obese Female in 2018. Awarded first prize for pre-paper pneumovasecoscopic repair of VVF. Very good. In Endogyne 2015 Kolkata. Daskan and Gold Medal Award for the Best International Publication by a PG student by North Zone USA for 2012-13. Very nice. Special training Urodynamics, passed the certificate course of Urodynamics of Bristol Urology Institute, recognized by ICS on 29/3/2019. So with this introduction, we can easily see his academic interest. In fact, in the PGI group also, he conducted a year back during Corona, every day one discussion topic, and we all enjoyed that. He is very keen in academics as well as teaching, and he has 10 MCH urologists training per year, is not a common thing. So Sunirmal, I am proud of you, and over to you for this supine patient and clinical scenarios. Please, thank you.
Thank you. So, can we start, sir?
Yes, please, please proceed. Share the screen and proceed.
Sir, I will start with the standard supine PCNL. Okay. It is
Yeah.
standard mini piece supine PCNL.
Yes.
So, can you see the presentation?
You are clicking it. It is not yet open. You click it.
Okay.
It is your document is seen, but it is not open yet. Is it opened in your laptop?
Okay, sir.
Yeah, re-share the screen, no problem.
Yes.
Yeah.
Yeah.
It is now open. Yes. Right.
So, supine mini PCNL. I'll go to the case first. So this is the case that we have done many supine PCNL during that period. At that time, I was in NRS Medical College. So there was 30 years old asthmatic female patient who presents right flank pain and right lower calyceal stone. So I will directly go to the slide now.
You stopped sharing screening. Why?
Okay.
Don't stop sharing screen.
Okay.
Directly you are presenting PPT, na?
Yeah, PPT.
Yes. Yes. Material methods we are seeing.
Yeah. So patient was positioned. You can see now.
Yes. You enlarge the screen.
So that yes. I positioned the patient in Gallocco modified supine valve position. I used to do supine position at that time in that position. I have changed the position now. Okay. So I have used the Olympus mini nephroscope and stone was augmented with pneumatic lithograph.
Yeah.
Now I am going to the video.
Okay. Why are you stopping sharing screen? Directly you
No,
can.
no, stop, stop. Okay, sir.
You should not stop the sharing screen.
Okay.
You go to directly video closing the PPT. That's all.
Can you see that?
No, no, you have stopped sharing screen. You should not stop that. Share screen. Don't click the button stop sharing screen.
Oh,
You use your laptop as if it is normal. Yes. Okay, video on. This is the first
okay, sir.
case. Uh,
So you can see that there is a lower calyceal stone, sir.
yes.
So this is my initial position, sir. This
Okay.
is the Galdacott modified position.
Okay.
This is somewhat obese female. So
Okay.
I have put the two bolster,
Okay.
and this is the initial position.
Yes.
So it is the
Oh.
classical Galdacott modified Galdacott position.
Okay.
You can see the position of Siam. I have position of Siam in 0 degree position at first.
Yes.
So I can move it both the craniocaudal and also anterior posterior. Normally in supine PCNL, we move the Siam in craniocaudal direction.
Okay.
So this is my initial arrangement. You can see I have taken both the mini nephroscope and also the standard nephroscope. And I used to do preferred serial dilation, serial Alcan dilation. So first ureteric catheter was placed, standard procedures.
Yeah.
So the advanced supine PCNL, we can do it by sitting position, sir.
Yes.
So that is ergonomically very friendly to surgeons.
Yeah.
So I used to mark my direction of puncture by a
Yeah.
glide rod. I always do that. I
Yes.
used to mark the direction of the puncture, sir.
Yes.
Then I put a small hole by needle.
Yes.
So you can see that the stone in the inferior calyx.
Yes.
So I have to hit the kidney in the right direction.
Yes.
Hitting the kidney in the right direction is very important.
Yes.
You may miss you may miss quite a few times, but you have to be very particular to hit the kidney in proper position.
Okay.
So you can see that now you can see that kidney is moving,
Yes. Yes.
and
Yes. This is a
now I
classical.
can puncture the kidney.
Shown very nicely. Classical.
Yeah,
This moves classically like this.
yeah. So then you have to put a guide wire.
Yes.
So the stone is obstructed. I am not satisfied with the puncture, so I am making some small adjustment now.
Yes. Yes.
I am making a small adjustment. You can see that I am making this adjustment
Yes.
because
Yes.
stone is occupying the whole of the calyx.
Yeah. Yeah. It is difficult case. Why? Because small stone, inferior calyceal stone, and impacted stone.
Impacted stone. That's the
Impact. Okay.
So now urine is coming. Okay. Initially that there was urine not coming freely. So now urine is coming.
Okay.
And we are putting a saline wasp from the ureteric catheter.
Yes.
It also helps in proper positioning of the guide wire also.
Yes. The guide wire has not gone into pelvis.
But ultimately, I have made some adjustment, and guide wire now you can see the guide wire has entered the calyces.
Very good. It's a
Few
difficult
adjustment.
case because the width of the stone is very less. Width
Yes,
of the
yes.
calyx is very less. You have gone little horizontally on the side of the stone
Yes,
in
sir,
the
yes.
most inferior calyx.
I agree,
So
sir.
this adjustment everybody has to do.
Yes, sir.
Agree very much. It is moved a
Then
little.
I'm
Yeah.
putting the glide rod up to
Very
the
good.
stone.
You crossed the stone or you did not cross?
No, sir. Stone is beyond the glide rod, sir. I have not crossed the stone, sir.
Very good.
I have not crossed the stone. Stone is there,
So
sir.
every time you are careful that you will stop at the stone, your
Yes, sir.
dilatation.
Yes, sir.
Problem is sometimes overshooting posteriorly or anteriorly may happen.
May happen, but then it will cause some bleeding, sir.
Yes,
And
sir.
the field will be obscured.
Obscured. Very good. This needs gentle till the tip
Yeah.
of the periphery of the stone only you are doing.
Yes, sir.
Excellent. And dilatation, how much size you have done?
It is up to 18 French. I have dilated.
What is this sheath?
Sheath, sir. It is the standard, sir. The Teflon sheath, sir.
Teflon sheath.
White colored Teflon sheath.
Yes. Now
So you can see that the stone is not visible.
Excellent. So no damage to the other side, and
No
is
damage, sir. No damage.
no migration of the stone.
No migration. Stone is impacted stone, sir. Stone is.
Yeah, it is difficult. It is difficult case. You will be just at the parenchymal edge.
Yes, sir. Ekdam just at the carousel edge.
You have to readjust again inside. You are doing now that
Yes, sir.
for this space. Laser is better. What did you use?
No, so at that time we have no laser at that time, sir.
Very good.
It is way back in 2018. We have no laser, sir, at that time.
Okay. Very good.
So I have to take lithoblast. There is no option.
Very good.
So this is the final thing. Final.
Very nice. So small stone doing PCNL is difficult. Small stone in inferior calyx supine PCNL is difficult.
Yes, sir.
In readjustment and kidney movement are very important signs. My only question here is, how do you decide external puncture site when you are aiming the needle towards the stone? Normally that is a blind part. If you have ultrasound, it's okay. If it is not there, how much distance? Because in supine PCNL, needle looks quite long towards the stone because you are keeping anteriorly.
So because the things are first, I see that's why what I used to do that I used to mark my direction of puncture by
Yes.
a alkane rod. Then I initially used to go somewhat horizontal to the plane.
Yeah, that means you are using exactly between the anterior abdominal wall and posterior abdominal wall,
Yeah.
center in the horizontal plane. That is actually very, very valid point. If you go more posteriorly, you will go posterior towards the skin. If you go more anteriorly into the peritoneum, you are saying that exactly in between the abdominal wall, you will go horizontally into the abdomen.
Yes, sir.
Yeah, that is
Then I have to mix. The thing is that I'll show you that initially I was doing in Galdoka modified position. In that position, you have to move the cilium in cranial-caudal direction, sir, rather than anterior posterior direction. So, but now I am doing in complete supine position. So it is very helpful because you can move the cilium also in anterior posterior direction also, sir.
okay.
I'll show it.
Second case.
Okay, sir. Second case. Second case is, sir, is a supine PCNL obese patient.
Very good.
Obese patient, you know that obese patient has very difficulty in positioning. The main problem is positioning the patient.
Yes.
So, sorry. So this is the PowerPoint presentation. So this patient has got a
डायरेक्टली सर्जरी के लिए चले जाओ, पावर पॉइंट प्रेजेंटेशन छोड़ दो.
yes, sir. It is a BMI of 42, sir. Just I tried for 1 year.
I'm not seeing anything here.
I'm going to the presentation now.
I'm not able to see the presentation.
Okay, just a minute.
You might have kept everything in one PPT, right?
So can you see the presentation?
No.
Okay.
You have to open it before I
Yeah,
think.
yes, sir. Just a minute. Huh? Can you see that?
Yes. Directly you play the videos every time.
Okay.
Don't go to PPT.
Okay.
Right. Anyway, we will get information here, na.
Yes.
This is a pelvic stone.
Pelvic stone, sir. You
No
can see that
patient.
BMI is 42, sir.
Now, did you
This
turn
patient BMI is
the?
42.
Have you turned the patient?
So it's very difficult to turn the patient, sir.
Yeah. So you are keeping an external view in
Yes,
an
sir.
alignment with the calyx. Which calyx you prefer in
Sir,
inferior, middle?
I'm going to lower calyx, sir. You can see
Lower.
that I'm going to lower calyx.
Why not middle calyx? Because I feel middle calyx is horizontal more.
Yes, sir, you are right, sir. I can also go that from middle calyx, But in that case, probably that infant neuron is more dilated in the lower calyx.
Okay,
So that's why I've chosen the lower calyx.
very nice. So you are going in horizontal plane.
The
Now,
problem in this case that we have to take a long needle, sir, because patient is obese. So distance is more than the standard needle size, sir. We have taken a long needle for puncturing the kidney.
which company produces the longer needles?
Sir, we are taking from Biorad only, sir, now. Because in hospital Biorad is available.
Okay.
There may be other companies also.
Yeah.
There are also the Blue Neem companies also got the long needle also.
Yeah.
So I'm going somewhat below the posterior axillary line.
Yeah.
Because of the gut of the patient is much wider, so you can see I am going below the posterior axillary line.
Very good. What are you trying to aim here without changing the degree? You are manipulating.
Yeah. No, I am functioning as in a monoplanar plane here, not a
Why
biplanar.
monoplanar?
Actually, not
Why,
a.
why monoplanar? Why you might have taken biplanar, no? Why monoplanar?
Probably I have punctured it and got the clear urine, so I am not gone for the checking in craniocaudal direction.
Okay.
But it is always advisable to check in bipolar position.
So you draw the posterior axillary line always in arm by the side.
Yes, sir. Yes, sir. I draw it before the puncturing. A patient, before entering the OT, I take patient to a side room in front of sister, and I mark the position by standing position. Actually, many people do it in the OT table itself, but I do it in standing position.
Okay.
Because I find that after patient is put on the OT table, there is some change in the position. So it is better to mark in the standing position.
What guide wire initially you will pass through the
guide wires are Kedmo guide wire. Normally I prefer Kedmo guide wire, but if there is a difficulty in passing the guide wire, then we take the PTFE guide wire, sir. The advantage of Kedmo guide wire that it goes directly to the ureter, sir.
ureter,
nicely,
because it is adjusts the PCS, it itself adjusts to the molds.
Yes, sir.
And what type of dilatation, alkane or single step or what?
I always do the alkane dilatation, serial dilatation, sir. From the very beginning, I am doing the serial dilatation because I feel that whenever you do a serial dilatation, you have a scope to stop at some point. If you see bleeding, so you can stop at that point. So first I do a Teflon dilatation, 6, 8, 10. You can see that I am doing Teflon dilatation, 6, 8, 10 first. Then I put the alkane cannula, sir. Then I put the alkane cannula to stabilize the system, and then there's the alkane cannula. You see, I always put this alkane cannula.
I feel once the alkane cannula is in the system, you are very safe.
Yes, sir. So you mean that you can go for diet dilatation?
Yeah. So water is coming freely.
Yes, sir, freely.
Now you are exchanging with alkane rod.
Yes, sir, alkane rod.
Very good. The person who is doing the Siam is showing from distant, but anyway, it's a when compared to the first case, its case is easy, but the problem here is obesity.
Obesity. The problem is obesity, sir. It looks easy, but it is not.
Otherwise, case is like a dilated system, wide infundibulum. Only thing is long ampla sheath and long needle have to be ordered. There are two cases where arshu kidney and supine PCNL obesity. We need to have long length.
So I'm stopping the video so that you can see that the complete clearance of the stone, sir.
Yeah.
Okay.
Go to next
So,
video like that only.
Next video, sir. Okay.
Don't share, stop sharing the
Okay.
screen. Go to the video folders and whichever you have.
So now I'll present one case of kyphoscoliosis, sir. I'll
Okay.
directly go into the video, sir.
Direct go to video because in
Yeah.
the summary it will be there. It is nice. First case, inferior calyceal stone, small one.
Can you see it, sir?
Yes, kyphoscoliosis present.
Kyphoscoliosis, sir.
Yes, nice. Where is the stone?
I'll show the stone, sir.
Yeah, that is the stone. Left side, located in the inferior calyx.
Yes, sir. Sir, we have first the stone. Actually, stone was a moving stone. So we have first done you are in this case, sir. So
Yeah.
whether that was stone was at the PUG at first time, it was moving stone, sir. It was moving between the PUG and the inferior calyx, sir.
Okay,
So
no
first
problem.
we have done in one URS, sir, in this case. But at that time, stone we thought that we will do laser URSL.
But RIRS is also a very good option in this case.
Yes, sir. But sir, at that time, RRs are not available in our
Very
institute, sir.
good. Very good. So you have to adapt to your own
Yes, sir,
technique.
we have to make adjustment as per our resources, sir.
Was the position any difficult? Just supine, that's all.
It is, sir. We have made a position, just supine position, sir, at ease of patient, sir.
So there is
Not
no
much
problem.
adjustment. There is not much adjustment. You can see that there is not an adjustment. It is
Yeah.
same as the other position. But you can see the posture. The posture gland is going much below as comparison to previous case. In obese patient, you see the posture at that point, but here it is much below, sir.
Yeah.
Can you appreciate it, sir?
Yes, much below.
Much below, sir,
Yes.
because of the ending of the spine of the patient. So I am marking the direction of puncture.
Okay. Did you turn the patient that side or it is just supine?
Just supine, sir. Just supine.
Not turning much, I think.
No, I'm not turning much. I'm not doing on complete supine position, sir. So I am hitting the kidney, sir. You can see I am hitting the kidney.
Yeah. This is the major advantage that when you go to the cup, it moves away and
Yes, sir.
deforms also. It deforms also. Then you will clearly get idea that you are nearer to
Yes,
it.
sir. Yeah, I can clearly get idea that I punctured it, sir.
I punctured it.
Yes.
In more, see like that. In more than prone, it happens in supine.
Yes, sir.
I also agree with this.
And also I can get the urine at once. You
Yeah.
can see that clear urine is coming, sir.
Yes. Very nice. What size dilatation you have done in this case? Small stone.
Sir, I have done that. I think I have done up to 20 French dilatation in this case, sir.
Did you change your attitude after finding the laser? Now you might be having laser in your institute.
Yes, we have got laser institute.
You reduced the size.
Laser 30-watt laser is there.
Very good.
So quanta laser is there in our institute.
Yeah.
We are doing some cases, but not regularly. We are using PCNL. We are more or less using in the URSL and RIRS.
Mini perc you use 12 French scope anytime.
Yes, sir. But
Then you should use laser. It will be nice.
That's why I'm saying that we are not using laser regularly in our cases.
Yeah.
Because there is only one laser, and we have got 3 OTs. So we have to adjust our resources as per our cases, sir.
Nice. This dilator is very useful, na?
Yes, sir. Very useful dilator, sir. This is very useful dilator.
This is a blue dilator with which is very useful. Initial dilatation 6 French, 8 French is very useful in supine PCNL where you make the tract in the rectus sheath as well as the gerotas fascia.
Yes,
After that procedure is easy, na?
Yes, after the procedure, very easy. The
Very
thing is
easy.
that there is some difficulty in initial dilatation.
Initial dilatation is more difficult than prone, I feel. What do
Yes,
you?
sir. Yes, sir. I
Yeah.
agree, sir.
Because
Initial
rectus
dilatation
moves.
is somewhat difficult because gyroid tend to kink. If
Yes.
you are not in straight line, gyroid tend to kink.
Yes. But very nicely you have recorded with enthusiasm. I appreciate that. Each clinical. So kyphoscoliosis is not common. I have done only 2 cases in my career. Both RIRS, of course.
I have already done 5 cases of kyphoscoliosis.
Very good.
So I will show another case of polio, sir. That is also kyphoscoliotic.
Yeah, actually kyphoscoliosis, there is chance of especially right side IVC injury, very common people say.
Yes, sir. That's I will show. This is a left side case. I will show a right side case, sir.
Okay,
For
okay.
that. So this okay. So we are done with the case now.
Do you think that in supine PCNL flushing from below should be very active to avoid bleeding?
Sir, it is not always necessary to flush the kidney from the below. It is only helps in clearing the small fragments of stone.
Okay.
Because stone is in dependent position. So if you flush from the below, the small fragments will come out. And also that the thing is the supine is the difficulty difficult thing that the system collapses, sir. The system collapses.
When system collapses, it looks the more bleeding.
Yes, sir.
In prone, that will not be there. Water retains.
Not the things in prone.
That is what I also feel. In live demonstrations, probably we feel that in the initial phase, supine PCNL bleeding will be more.
Yes, sir.
So that's a concern. Very good.
Okay, sir.
So
I'm going
small
to the next
stone
case.
doing is difficult, and you nicely demonstrated.
Yes, sir. Yes.
So we have done.
Patient. The next day, you can see patient sitting and only a small hole, sir. The next day picture is, sir.
Nice. This is the third case. One obesity you have shown, one small inferior calyceal stone you have shown, one kyphoscoliosis you have shown.
Now I'll go to a diverticular stone, sir. It's a very interesting case, sir. Diverticular stone, sir.
Nice.
Okay. You can show a diverticular stone.
Yeah, I can see the left side diverticular. I mean, yes. Very
you
good.
can appreciate the diverticular stone, sir, here.
Left upper pole,
Upper pole.
diverticular stone.
Upper pole diverticular stone, sir.
Very good.
That means it needs the upper calyceal puncture, sir.
Right.
So that many people say that upper calyceal puncture is very difficult to find PCNL.
Yeah.
But it is not so, sir. In this position, now you can see the position, no, sir. I'm going back, sir. I'm going back.
Yeah.
So, sir, this is now I am now preparing this position, sir.
Yes.
I am now place the patient in complete supine position, sir.
Yeah.
I will explain why I now because initially I started with modular position. I now position the patient in complete supine.
Yeah.
Then you can move the C-arm in anterior posture and also in cranial-caudal and anterior posture, both.
Yes.
So
see, the bolsters make it 10-degree rotated. That is sufficient.
Yes,
that is more than sufficient.
10-degree rotation, sir.
That's more than sufficient. This also recently, I feel that it is clear. You can easily access all cases. Very nice. Very good. You have to go little more posteriorly here because
yes,
it's
a
superior calyx will be more posterior.
Now you can see that I am directing the needle somewhat below because superior pole
see
is somewhat below.
See the kidney movement will be very much in supine PCNL.
Yeah.
That clearly shows you are nearer to the target.
Nearer to target, sir. Yes, sir.
But only thing is that in these cases, do you expect saline? It is coming good.
Sir, it is coming, sir. Maybe there is small communication is there.
Yeah. If not there, what will you do?
Sir, if not there, if there is this, I will do some, sir. I will do push some betadine from the below, and if it can see something of betadine, then I am sure that.
Very good.
Sir, you can see that I am putting a PTFE guide in this case because that will park in the that small diverticulum, sir.
Yes.
This PTFE guide, sir.
Very good.
So you have got any suggestion?
No. Very nice. The only thing is I am worried is if the guide wire doesn't go PTFE or Terumo,
yes,
a small 1 or 2 centimeters guide wire also, you should do immediately alkane dilatation first.
Alkane dilatation.
Alkane dilator, feel on the stone and stay back there. Not this, direct alkane rod. In all cases, you do this.
I do in all cases, sir.
What is the advantage
I have made some standard steps because then my students also do the standard steps. You can change your steps as per your practice, but I do some standard steps, sir, always.
So this alkane is the first one which you have shown is from the starch, na?
Yes, sir. Yes, sir.
Two-piece dilatation.
Yes, sir.
And through that you will pass the alkane rod.
Yes, sir.
Okay.
And then serial dilatation.
Okay. No single step. Direct.
I usually do not do single steps, sir.
I also don't do. Honestly, I don't do. It will take only 2-3 minutes.
Yes, sir.
But
It
lot
takes
of
only hardly 2 minutes, sir. Hardly 2 minutes,
yeah.
sir.
The people say by reviewing and putting you will get bleeding, but I don't know. I feel safe.
I feel very safe with this because wherever I saw the tinge of blood in the catheter, because I always have a look on the catheter, how
Yes.
the fluid is coming.
That
If
is
I
a very,
saw
very
then I
important
stop
point
at
when
that
you are
point,
doing
sir.
PCNL. If you see in the Foley's catheter what is happening, it
Yes,
will
sir.
help a lot.
Yes, sir.
If it is severe bleeding, we have to rethink what we are doing.
And this thing is very important, sir. The fixing of the guide wire, sir. To the
Yes.
side of the,
Yes.
you can see that I am fixing the guide wire
Yeah, yeah.
because it is my lifeline.
Yes. Till you see the stone, it is lifeline in this case.
Yes, sir.
After seeing stone, okay, no problem. Once you see the stone, we are happy.
Yes, sir. So after a few adjustments, so minor adjustment, I can see the stone, sir.
Very good.
This is the stone,
Very,
sir.
very happy to see this stone and
Yes, sir.
nice. Laser is very useful in such cases.
Yes, the laser is very useful, sir. I agree, sir.
Because opposite side infundibulum will be narrow, forcibly it may tear
Yes,
with
sir.
a
Yes,
pneumatic lithotripter.
yes, sir.
Whereas laser stone doesn't have any retropulsion, just finish in little time it takes, but
Yes, sir.
fine.
Now, that's my point, sir. Even if you don't have laser and another valuable gadgets, you can still perform supine PCNL with minimal resources, sir.
Yes.
You can still perform it with the standard lithoclast, with standard your nephroscope. You can perform supine PCNL.
Yes.
And no, nothing else is required actually.
Yeah. Lithotripter also should be good. Otherwise,
Yes,
you force and it may cause bleeding trauma.
Yes, sir.
These are all closed spaces.
Uh,
So you have to be. Generally, I remove guide wire Sunirmal in supine because it won't be so
okay.
easy. But
I agree, sir. Because if you remove the guide wire, then you can get some space, sir.
yeah, the guide wire definitely will feel removal of the stone difficult. Very nice job.
Okay.
Excellent job.
So we are going to next case, sir.
Yes.
It is a final picture.
Very good. So one inferior callicial stone, one pykoscoliosis, one obese patient, one
Diverticular stone.
diverticular.
So 4 cases are completed. Now I show one case of ADPKD, sir.
Oh, very good. Good.
So this is ADPKD. Yes.
I have not done ADPKD, supine PCNL, prone I have done.
Sir, I have done, sir, now I have done more than 6 cases of ADPKD. And also our article is now accepted in Journal of Urology in case of ADPKD, sir.
Okay.
You can see this, sir.
Yes. Same type of first type of stone.
Yes, sir. Sir, this patient has got stone in both sides, sir. Right side and left side also. We have first done you are on right side, sir. And
Okay.
then put a digestion on both sides, sir. Initial.
Very good.
So in not in this setting, sir. Before this 1 week before this operation, sir.
Oh, very good.
So we have done right URSL and left both side digestion things, sir. And
Yes.
then for left PCNL.
Very good.
So this is the position. You can see the complete supine position. The markings. The problem in ADPKD that the CM picture is not very good, sir.
Yeah.
Because I can show the stone is here, sir. Stone is here. I'll show the stone, but CM picture is because of the, I think most of it is because of the cyst. I think the CM picture is not good at that time, sir.
That is dangerous because you should have a good medical acumen to
Yes,
hit
sir.
the stone. Otherwise,
Yes,
you will be, and that too, saline may come as if you are in the.
Yes, sir. The problem is, second problem is that whether it is saline or cyst fluid, you have to you are not very sure. So we have to be very sure after when the clear fluid is coming, because the cyst fluid is somewhat yellowish, more
Yes.
yellowish.
Yeah.
try to show the puncture in the Sian view. So this is here is the stone, sir. You can show here is the stone, sir. There is a stone. I have to make some adjustment.
So medial and
view is not very
superior.
clear in this case. It is more blood in video also.
Yeah.
There is more blood here, but because of the academic purpose, I am showing this case.
No problem. It is difficult actually. Why? Because the PCS will be compressed. Getting saline from the this thing is itself is good thing.
So I can put a guide wire there at least, and then I can see that urine is coming.
Yeah.
After putting the alkane cannula, I can see the urine is coming, sir.
Good.
So then the steps are after alkane cannula is there, sir. Then the steps are very
Steps are same, easy.
same. Where then the steps
Only
are very
getting
easy.
an access. Actually, middle calyx is easy. Inferior calyx is little difficult. We have to sometimes overlapping on the spine will be there. We have to identify the stone carefully before we puncture.
Yes, sir. So clear fluid is coming. The thing is that in ADPKD, the problem is that if you puncture the cyst, initially there will be some fluid and then there will be bleeding, sir.
Yeah.
And you will be completely lost in those cases, sir.
Yes.
So you have to be very careful. You should not be in a hurry in those cases. You should give some time in puncture.
Yes.
And now you can see that I put a nephrooscope and you can see the nephroscopic view. And this is the view. There is some cyst also beside the stone.
Very nice. Very nice.
So we have to make it quite a few pieces because stone is actually more than 1.5 centimeter. We have to make it quite a few pieces.
Yeah. Hard stone.
It is hard stone. It's a very hard stone, sir.
Yeah. Usually they are.
So you are doing, sir, RIRs in those cases, no, sir?
Cases, but they are very hard and infection chances are very high. Post-operative fever is very common in ADPKD. Very nice.
So what you are preferring, say, in ADPKD case, you are doing RIRs preferably, or
if it is less than 1.5 centimeter RIRS, if it is a large stone seen, then definitely PCNL. 1.5 centimeter only RIRS.
So you can see, sir, that stone is cleared, and we have just a small one, and these are the stones, sir. Urine is completely clear, sir.
Excellent.
So I am going to the next case. It is a very interesting case, sir. It is a very interesting case. It is a case of polio, sir. I recently operated this case of poliomyelitis. So she came to us. She had got also bilateral stone. So we have done.
Have you ever injected methyl blue so that you can identify better cyst or this thing like that?
Yes, sir. We can inject methyl blue, sir. I have in other case. I have in some in another case I have injected methyl blue, sir. Methyl blue is also very helpful, sir.
Okay.
And also you can also inject some dilute betadine, sir. The dilute betadine, the color of dilute betadine is separate from the cyst, sir. Not the same.
Yeah.
So this is the can you see, sir?
Yes. This is
poliomyelitis, sir.
Poliomyelitis,
sir. Poliomyelitis has got both limb deformity and also kyphoscoliotic kidney. So you have actually a patient has got. I will stop here.
Yeah.
See the position of the patient, sir.
Yeah.
Just a minute. Sir, see the position of the patient. The patient, I cannot put him in a standard supine PCNL position, sir.
Yes.
It's not possible. We have to position at the liquidity of the patient. So it is not a standard supine PCNL position. As per her limb permits, we have positioned the patient, sir.
So in the preoperatively only we can see which position patient will be comfortable.
Yes, sir. We have to assess the position because we cannot stress the limb.
Yeah. Muscle contraction will be there, so you can't.
Contraction will be there.
Yeah.
So it is a free position, not a standard supine position. No, not it is not supine, not also Galdoca moderate position.
Yes, yes.
So patient has got obstructed stone, so you have put on a PCN initially before the surgery. Sir.
Yeah, yeah.
So you can see the kyphoscoliotic kidney, sir. I have used actually I have done 2 punctures and used 2 scopes. One is Olympus scopes and another is wood scope.
Why 2 punctures?
Because I will show why there was another stone is there. Actually, after clearing the stones from the inferior calyx, we found there is a stone in superior calyx also, sir. So we have made to make another puncture, sir. It was not accessible to the lower puncture, sir.
Yeah, yeah.
You can see.
Yeah.
Going to the top of the calyx. And you can see the spine. Spine is totally kyphoscoliotic, sir. And
Yes.
the thing is that I am very near to the main vessels.
Yes. నేను కుప్పవాళ్ళ అంకుల్ వెబినార్లో ఉన్నారు, ఫోన్ చేస్తారు.
Sir, you are doing supine PCNL in different ways, sir.
Same. There is no way you can do differently. Same like lithotomy, ipsilateral limb, lower side or straight. Only bolsters making 10 to 15 degrees turn, and same way I am doing. No difference at all. Only thing is that I use a flexible ureteroscope as a ureteric catheter.
Okay, sir.
I pass a flexible scope along with sheath always.
Okay.
So any stone which I cannot, immediately I will do RIRS and get the stone to PCNL person.
Okay, sir.
I will always keep ECIRS as the option. Always.
Okay, sir. Okay.
So I don't
first go for ECRS, then supine PCNL.
No, supine only. But any problem is there, I will be ready with the RIRS scope.
Okay, sir.
I don't put ureteric catheter, I put access sheath.
Okay, sir.
Unless the ureter is tight, I will not do on that day. Ureteric catheter I will put.
Okay, okay.
You
So
understand?
you are always taking 2 monitors, sir. You are always taking 2
Two monitors always if required. I will have, option to do RIRS always. That is the main reason why I have shifted to supine PCNL, Sunirmal.
Yes, sir.
That is because my RIRS work is more. Whenever large stones are there, I have to spend lot of time in RIRS. So I can do immediately. Right, very good. You are seeing the stone here.
Yes, sir.
Very good. Nice. No bleeding, nothing.
The stone is a large one.
Yeah.
So I am just picking the stone to bring it to a more accessible position.
Yeah. Good pneumatic lithotripter and forceps are also essential in supine.
Yes, sir.
Sometimes the water flow is good, it is nice. Shaw suction is also very good. You try
Yes,
sometime.
Yes, sir.
Very useful.
Planning to buy one because I know that is very helpful.
Very
you are
helpful.
using also, sir.
Yeah, I am using. So good cases you have collected. Good.
So, sir, you can see, sir. Just I will stop at that point.
Yes.
So you can see that there is. Sorry, sir. I want to show something.
Yeah. Take time, no problem.
Sir, you can see that there is one stone left here.
Yes.
There is one stone left here.
Yes.
It is not accessible through this puncture, sir. I have tried to it, but it is actually in parallel.
This is what exactly I am telling Sunirmal. I will put flexible soap and bring it back to him.
Yes, sir.
That's all. That's the only point I wanted to add.
Yes, sir. So I have punctured, sir. That I in this case I punctured again, sir.
Very good,
So,
very good.
I can say I can show you that this is a puncture. Actually, this is the second puncture. I have not shown it in this video.
Ah,
This is the second puncture.
very
I'll
good.
show in the CM. I'll show the CM view, sir. I'll show the CM view.
Yeah.
This is the second puncture. This is the upper calyceal
Was
puncture.
it stone guided or calyx guided? Was it stone guided or calyx
It
guided?
is a more or less stone guided puncture, sir. I'll
Okay.
show the puncture, sir. This is the needle, sir.
Ah,
And
okay.
here is the stone, sir. Here is the stone. This is the stone. Can you appreciate the stone, sir?
Yeah, I can
Here
see
is the
that.
stone. So I am going somewhat stone guided puncture here.
Okay. Yeah, this shows precision. See, any small stone tackled by PCNL is precision. Lot of people say I have done big stone, that is good, but actually PCNL is more difficult for less than 1 centimeter stone.
Yes, sir.
Especially
The director is going, sir. Nicely.
yes.
So I have done dilatation is there only, sir. I have done. I think I have done 15 years dilatation, so that I can pass a mini scope here.
Some people advise flushing of the stone, which can come down and then you can take out from the other.
So I tried that. It was not coming, sir.
It was not coming.
Always says that, and in his cases, always the stones comes down. But in my case, it is not possible.
It's not easy. Infundibulum should be wide.
So, can I present say another case, sir?
Present. No problem.
So I am going to, sir. I think I have presented 6 cases. I am going to another case. It is a very interesting case because initially my anesthetist told that the patient has got COPD. So it is very difficult. It will be not possible to give GA in this case. So you do it supine PCNL in spinal anesthesia.
Very good.
I normally do supine PCNL in GA anesthesia.
Yeah, I also do under GA. So many people
I normally do under GA, sir.
Yes.
I've done only few cases in spinal anesthesia, but this case is the patient is not very cooperative, sir. I know the patient is not very cooperative.
Actually, supine PCNL under spinal is difficult because your kidney movement will make it little frustrating.
Yes, sir.
I do agree.
Show in this video, sir. That thing I will show, sir. Can you see this, sir?
Yes.
Yes, sir. So this is the case of COPD with bilateral renal stone disease, sir.
Okay.
COPD with bilateral renal stone. Patient also hypertensive. Lot of comorbidities there. He has got bilateral renal stone disease, and he came to us first in the OPD. And there's suspicion of also right side PUGO, and we have first tented the patient, sir, in OPD basis.
Okay.
There's a large stone. So patient is under spinal anesthesia now. They put the patient on spinal anesthesia. This is a large stone. So patient is breathing at his will, sir.
Yes.
He's not following my command. He's not following my command, sir.
Yes.
Because it's not possible for him to follow
No.
my command.
If I tell you will do more breathing, I have seen many times. Patient should be very intelligent, should be trained. Headache. But in certain cases, like this, COPD, which anesthetist will be comfortable to give GA in COPD?
Yes, sir.
It's even after controlling also, this is the true advantage of supine PCNL, to be honest.
So I have to wait for the kidneys to come in front of me.
Yes.
I have to position the needle in front
And
of
in a fraction of a second, you have to puncture.
Sir. This is a very interesting puncture. You can see that I have directed the needle in front of me and waiting for the kidney to come. So kidney is moving patient is moving his lungs at his will.
Very nice.
Kidneys will come at one point. So just I am waiting for that, and now I can puncture the kidney, sir. It is a wide infundibulum calyx, so there's no problem. But I have to wait for that time.
Should I tell one thing, a small thing? Very nicely you have demonstrated. Alken sir says that in toilet paper, when you pull, it will be coming. You have to pluck it fast to break it.
Yes.
In airports, you see, if you pull, entire paper will come out.
Yes,
but if you want to break it, you have to break it fast. That moment the kidney comes down, you have to quickly, you should be ready at the kidney and then puncture.
Yes.
Very nice.
Yes,
luckily, you have little broader infundibulum, so.
But that is helpful for me, sir, because our broader.
By any means, supine PCNL in spinal anesthesia is difficult.
Yes, sir.
I have done few. You have to be quick, and patient should give some pause at least.
Yes, sir. If patient is not cooperative, then it is very difficult, sir.
Very difficult.
Patient is cooperative, it is okay, sir.
Some
because lot of people are doing supine PCNL only in spinal anesthesia. I heard, sir.
Yeah, yeah.
But I don't
Prone
know.
PCNL, many people in India do spinal only.
Yes, sir.
Prone in thoda kidney movement will be less because it is pressed
Yes, sir.
by the abdominal muscles, but supine it moves a lot.
Supine is moves a lot, so it is very difficult in supine. Prone
Yeah.
also that in spinalis is difficult, and all in our set of spinalis is not willing to give PCM spinalis in prone PCM, because the problem is that if anything goes wrong, I don't know, then it is very difficult to intubate at the prone position.
Even my mind feeling, I am a strongly GA person, so patient will be comfortable is my feeling. But
Yes, sir.
in India, many people do Sunirmal under spinal, and
Yes, sir.
they have lot of vast of experience in districts and districts. They do lot spinal because surgeon anesthetist will be very comfortable in spinal. They just sit. Very rarely, if the surgeon is good, nothing will happen. Is the feeling that is true
Yes,
all,
sir.
but cost effective Sunirmal.
Very cost effective. So I think spinal is very cost effective. I
Spinal
agree,
is
sir.
very cost effective.
Cost effective.
Maybe difficult, but in good hands it is very cost effective. A minimum 5 to 10,000 rupees, it will be less. Big stone.
Big stone, sir. Large stone. Took quite a lot of time to
You need
like the
patience.
stone.
Um, See, this breaking is
So
also difficult in smooth stones.
yes, sir.
Frustrating sometimes.
Frustrating, sir. It is very frustrating.
So
But
laser
at
is
last
very.
we can clear the calyx
See the collapsed nature
completely.
of the supine PCNL. Totally
Yes, sir.
collapsed system.
Totally
Totally
collapsed. You can see
collapsed.
that the system totally collapsed, sir.
Yeah, that will not be there in
Very,
prone. That is the advantage in prone, in fact.
yes. So you can the patient is cleared of stone now, sir. The only small puncture, the event is clear.
Very
And
good.
we are planning for the left side supine PCL later.
Very
So
good.
just I have finished my presentation.
Very
I will
good.
just share some tips for the
Please.
if you give me permission for 2 minutes
Yeah, please,
extra.
please. Please open the presentation.
Okay, sir.
Some tips for the juniors for regarding supine PCNL with very good experience and different
Yes,
type
sir.
of cases.
Can you see the presentation?
Yeah, yeah. No, you
So,
will have not seen.
huh?
Somehow your PPT is a problem. What you have to do is stop sharing and then open the PPT and then go for it.
Okay, okay. Stop share.
Open the PPT now in your laptop
Okay,
and then share the screen directly. It will be visible.
okay, sir.
Yeah. See now it is correct. So anytime if you do Zoom, open the PPT and then share.
Okay, sir.
ये डीए
So,
क्या है? डिप्लोमा इन एनेस्थीसिया किया तुमने?
yes, sir. I have also done diploma in anesthesia,
Very good.
and also I have practiced anesthesia for some days also, sir.
Very
So,
nice. So quite hard work in life.
okay, sir. Thank you, sir.
Fantastic.
So this is the history of supine PCM.
Yeah.
Just for just for the information, it is started in 1987. I'll not go. I'll go to straight to the preparation. I have to go to preparation. You can see that bowel preparation is controversial. Some people do bowel preparation. Some people do not do bowel preparation. So it is not mandatory to do a bowel preparation in supine PCNL.
Very good.
Okay.
Even we
And
don't do.
prepared GA as you said, patient positioning. So the thing is that initially Gadlako started in this position. So
Yeah.
then the thing is that then there is evolution of position. First,
Yeah.
Gadlako started in this position. We put a bag there.
We are not
You can see
doing
the
like
bag.
that.
Okay. But nowadays, I shifted to this Justi position. You can see that I'll show this position. This is the Justi position, sir.
Yeah.
This is very helpful.
Yeah.
That the Justi has done this position because you can maneuver the scope better.
Yes, yes. Even
That's
the
it.
upper ureter going in Gusti position is easy.
Easy, sir. So I started the PCL by in this position, in classical Gadlako position. You can see I started it in this position. I started in this position, and then I shifted. This is my initial position, sir. This is my initial position. By just copy. I'm just copybooking the books of supine PCNL. But later I found there's difficulty in maneuvering the scope here.
Yes.
Difficulty in maneuvering the scope. So I realized that I will go for complete supine, sir. So I've changed my position, keeping the leg completely supine without any stirrup, help in maneuvering the scope here, sir. You
But
can
only
maneuver the scope better.
if you keep straight like this, RIRS cannot be done. If you
Yes,
flex,
I agree, sir.
if you flex little bit, both
Yes,
RIRS. One more thing, RIRS, ECIRS, supine PCNL, and laparoscopy also can be done in the same position.
Yes, sir. Yes, sir.
So only one position for all.
Yes, sir. So there's the important tip. I want to share one important tips that puncture is made posterior to posterior axial line in 0 degree using triangulation in triangulation technique. The most important tips for puncture is the tip of the needle when goes on opposite side or moving the C-arm, your needle is superficial. If it moves in the same direction of C-arm, the needle is deep to the desired place of puncture.
Yeah,
If your needle tip remains same in both 0 and 30, you are in right position, sir.
very good.
So that is nicely depicted in this picture. Sorry. Yes. So this is the picture. This is the rotate the C-arm in 30 degree, whether
Yes.
your puncture is reached or not. If you feel that it is below the calyx on X-ray, puncture has gone anteriorly, sir.
Yes.
So you have to go posteriorly.
Yes.
And if you find the needle above the calyx, the puncture has gone posteriorly.
Yes.
So this is my initial experience. I have published quite a few papers in supine PCNL. This is one of the papers in supine mini PCNL, and it is published in another paper is the supine versus prone PCNL in calyxal stone. Number studies published in Urology journal. You can go through this. We have presented our paper there, our findings there, and we found that supine PCNL has the tone free rate is more in supine PCNL.
Yeah.
In our study.
Okay.
So I completed my presentation, sir. If you
Thank you.
want to ask any
So
questions.
it is a very good presentation. Ashutosh Kumar has appreciated that it is every possible scenario has explained. Sandeep Srivastava has told very nice video presentation. One of the doc, I don't know the name, he has asked questions and you covered everything. Good that R.K. Gopalkrishnan sir also has a elegant presentation he mentioned. I think a lot of people have seen, 150 people have seen the presentation. And I must appreciate that you have already published this and good. I will stop sharing the screen.
Okay.
And there are, I think we have covered enough. It's just an hour or so. So with this, we will conclude the session. Excellent job you are doing, and proud of you that you have recorded so well. And most of it is giving the proper idea how to do it. And variety of cases like these 7 cases are very useful. And it will be a complete record. In fact, Sunirmal, day after tomorrow we have Gudo Gusti sir talk in Pure. So don't miss. Endourology extending its horizons, simultaneous bilateral endoscopic surgery, where one side supine PCL and other side RIRS will be done. He is the one who is inventor in that. So all the urologists who are watching the program, please inform your friends and join the Pure, and then we will exchange the knowledge and learn the surgical technique based presentations. Thank you, Sunirmal, once again.